Assalamualaikum and hi. Our group will present about the potential pitfall and mindmap of lung cancer in cytology. So, this is our group member. Assalamualaikum and hi, my name is Alia Sofia. I will begin this presentation with the introduction to the potential pitfall and mindmap of lung cancer in cytology. So, as we know, cytology is widely used for the diagnosis of lung cancer because it is minimally invasive and cost-effective. However, the interpretation can be challenging as some benign or reactive cellular change may closely resemble malignant feature. These challenges are known as diagnostic pitfall and mindmap, and they may lead to the misdiagnosis if we not carefully recognized. Next, I will proceed with my part of the presentation, which is the great mindmap in lung cancer cytology, which is reactive type 2 pneumocyte. So, what is the reactive type 2 pneumocyte? It is considered one of the most important mindmap of lung cancer in cytology. Normally, this cell function in significant production but proliferate during lung injury or inflammation. So, when reactive, they may exhibit a typical cytological feature that closely resemble malignant cell, particularly in a lung adenocarcinoma. So next, the cytological feature of reactive type 2 pneumocyte. Cytologically, these cells appear enlarged with round to oval nuclei and prominent nucleoli, which may raise suspicion for malignancy cell. However, the nuclear membrane are usually smooth and the chromatin remain relatively uniform, which help us to differentiate them from malignant cell. So, next is the etiology of the cell. The reactive change are triggered by the condition that damage the alveolar epithelium, such as pneumonia, pulmonary infection, and lung trauma or injury. This change represent a reparative response rather than malignancy. So, next is the diagnostic pitfall of the cell. In the repair process, this cell may closely mimic malignant cell. It may show nuclear enlargement, nucleoli prominence, vacuolated cytoplasm, and also small cell cluster, which can resemble feature of lung adenocarcinoma, making them one of the most common diagnostic pitfall in lung cytology. So, lastly is the comparison between reactive type 2 pneumocyte and lung adenocarcinoma.
Assalamualaikum and good morning to Senazri and everyone. I am Nur Aliahanan Nur Azan Zaki. Moving on from reactive pneumocyte, I will be discussing the mimics of mucin. So what are the pitfalls? Here we are looking at two major biological traps, which were goblet cell hyperplasia, a condition consisting of an increased area and number of goblet cells in lower airway. Next, bronchial cell hyperplasia. A growth response of bronchial cells consists of tight papillary cluster with occasionally molding and variable numbers of mucus-producing cells, often called corolla bodies. Now, why we call this mimic? Goblet cell hyperplasia is the perfect double for metastatic signal ring cell carcinoma because both contain large amount of mucus vacuoles. On the other hand, corolla bodies mimic adenocarcinoma because both form highly cellular cluster. Let's dive into the specific cytology features for goblet cell hyperplasia. These cells contain large, distended cytoplasmic vacuoles filled with mucin. This vacuole often indent the nucleus, pushing it to the very edge of the cell to create that signal ring cell appearance. However, we can avoid this trap by looking at the benign clues. The nuclei are small, uniform, smooth nuclear membranes, and fine chromatin. Unlike cancer, the background of these slides is usually clean, lacking the cell debris we see in true malignancy. Now, let's put this side by side so you can see the diagnostic challenge. On the left, you can see a goblet cell hyperplasia. Notice the large mucin vacuole in the nucleus, giving it that classic signal ring shape. But look at the nucleus itself. It is small, smooth, and basal. Now compare that to a true signal ring cell carcinoma on the right, where the nucleus will be much larger, darker, and show irregular borders. Next, we have corolla bodies, which are tight, three-dimensional papillary cluster of bronchial cells. These are very scary because it shows nuclear molding where the cells press against each other. But here is our clue, the presence of cilia or terminal bars. We also look for round to oval nuclei that all look consistent rather than the wild varying size seen in adenocarcinoma. Let's put it side by side. Look at these corolla bodies. It is a dense three-dimensional ball of cells that looks very much like the adenocarcinoma cluster next to it. Both show high cellularity in the corolla body. If you look closely at the high-power view, you will find cilia or terminal bars. These structures are the gold standard for benignancy. How to differentiate? Look at the benign clue. First, the presence of cilia and or terminal bar is the most reliable sign of a benign process. Second, nuclear morphology. Benign cell has small, uniform, round to oval nuclei with smooth, thin membrane. Third, chromatin pattern. Look for finely granular chromatin rather than the coarse clump chromatin seen in cancer. Fourth, the background. Benign specimens typically have a clean background, whereas malignancy often shows necrosis and debris. Lastly, clinical correlations. Always cross-check with patient history whether have asthma or COPD and radiology absence of a discrete mass. That's all from me. Thank you.
I am Nurin Sofia and I will continue with adenocarcinoma mimics, which are benign tumors and therapy. Here is the picture of lung adenocarcinoma that we have already learned before. It arranged in 3D clusters in single or glandular arrangements, has high NC ratio with nuclear enlargement, pleomorphism, coarse chromatin, prominent nucleoli, and vacuolated cytoplasm. Next, let's get to know first lung adenocarcinoma mimics from this topic, which is pulmonary hamartoma. It is the most common benign tumor of lung, but often misdiagnosed as a malignancy. So, pulmonary hamartoma consists of two types of cells, which are epithelial and mesenchymal elements. The epithelial cell is bronchial epithelial cell, characterized by sheets of small, uniform, simple columnar cells arrangement, round to oval nucleus, smooth nuclear membranes, fine to coarse chromatin, inconspicuous nucleoli, has cilia, and scanty to moderate cytoplasm. Then, mesenchymal elements are cells and tissues that form the body's connective and supporting structures. The arrangement of this cell is usually in single or loose form, oval, centrally located nuclei, prominent nucleoli, and usually it has an extracellular matrix, which is pink or mucoid substance that can be seen in the background. This is the picture of pulmonary hamartoma, which consists of bronchial epithelial cells and mesenchymal elements. Secondly, therapeutic effects from radiotherapy or chemotherapy. It occurs in response to radiation or chemotherapy that cause cellular changes. These benign cellular changes is already learned in the last semester. Its characteristics are arranged in group or single, is cytomegaloid, which is the nuclear and cytoplasmic enlargement with mildly high to normal NC ratio, hyperchromatic color, prominent nucleoli, irregular nuclear membranes, nuclear and cytoplasmic vacuolation, degenerative nuclei, and polychromasia. Last but not least is clear cell sugar tumor. It is a very rare benign tumor and it's named sugar tumor because of its high glycogen content. The arrangement is in clusters, has polygonal and spindle shapes, round to oval nucleus, mild pleomorphism nucleus, smooth nuclear membrane, fragile cytoplasm which is stripped, creating a vacuolated, granular or foamy background, and naked nuclei. The background often contains delicate, transgressing blood vessels. So, transgressing means the blood vessels are crossing through group of cells like a thread through a bead.
Next, squamous cell carcinoma, SCC, and its mimics. In lung cytology, squamous cell carcinoma is usually identifiable by keratinized cells, hyperchromatic nuclei, coarse chromatin, and tumor diathesis. However, several non-malignant conditions and technical artifacts can closely mimic SCC, leading to false positive diagnosis. The major pitfalls include squamous metaplasia, pulmonary infarction, and vegetable matter contamination. First, squamous metaplasia is a common reactive change caused by chronic irritation, most frequently due to cigarette smoking, chronic inflammation, tracheostomy, or repeated instrumentation. In this process, normal ciliated columnar epithelium is replaced by squamous epithelium as an adaptive response. Cytologically, squamous metaplastic cells show well-defined cell borders, dense cytoplasm, and increased nuclear to cytoplasmic ratio. When atypia is present, these cells may appear hyperchromatic and irregular, closely resembling squamous cell carcinoma. However, unlike true malignancy, squamous metaplasia is non-invasive, more uniform, and lacks tumor diathesis, and correlation with clinical history is essential. These are the pictures that can compare SCC and also atypical squamous metaplasia. The second major pitfall is pulmonary infarction. Pulmonary infarction occurs due to interruption of blood supply, most commonly from pulmonary embolism, leading to ischemic necrosis of lung tissue. Cytologically, infarction causes reactive and degenerative atypia with atypical bronchial or squamous cells showing enlarged nuclei, coarse chromatin, irregular macronucleoli, and occasional keratinization. These features can closely mimic squamous cell carcinoma. However, there are clues that suggest infarction include smudged degenerative nuclei, low cellularity, abundant necrosis, and hemosiderin-laden macrophages. The third pitfall is vegetable matter contamination, which is a technical artifact seen mainly in sputum samples. Food particles such as asparagus may appear as rectangular or polygonal cells with thick refractile cell walls and dark staining cytoplasm. These features can be mistaken for keratinized squamous cells. A key distinguishing feature is the presence of a rigid plant cell wall, which is not seen in human epithelial cells. These are the pictures attached to compare SCC and vegetable matter.
Next, I will explain on small cell carcinoma or SCLC and some of its important diagnostic mimics in respiratory cytology. This topic is clinically significant because SCLC is a high-grade neuroendocrine tumor with an aggressive course and poor prognosis. A misdiagnosis can lead to inappropriate management. The image shows classical cytological features of SCLC. It is high NC ratio with scanty cytoplasm, hyperchromatic, and inconspicuous nucleoli. The most important diagnostic clue is nuclear molding. Finally, the background shows proteinaceous background. One of the major pitfalls in diagnosing SCLC is what we call the carcinoid trap. This happens when carcinoid, which is a low-grade neuroendocrine tumor, is mistaken for SCLC. Because both tumors share neuroendocrine features and may appear as small cells with scanty cytoplasm. In poorly preserved or crushed samples, important features such as nuclear molding or necrosis may not be obvious. In carcinoid tumors, the chromatin has the classic salt and pepper appearance, the cells are more uniform and the background is clean with little or no necrosis. In contrast, SCLC shows darker nuclei, thicker molding, and dirty background. Another important mimics of SCLC is lymphoma, including post-transplant lymphoproliferative disorder or PTLD. Lymphoma can look similar to SCLC because the cells are small and have a high nuclear to cytoplasmic ratio. Lymphoma cells are typically discohesive, meaning they do not stick together. The nuclei shows smooth chromatin with small indistinct nucleoli. Most importantly, in the background, we can see lymphoglandular bodies, which are small cytoplasmic fragments and a strong clue to a lymphoid origin. Unlike SCLC, there is no true nuclear molding. Any apparent molding is usually due to crushed artifact.
Next, my name is Nur Batrisha binti Muhammad Khairul Nizam, and I will explain the technical pitfall and accidental contamination. We start with crush artifacts. What is crush artifacts? Crush artifacts refer to a false distortion of cells caused by mechanical pressure during specimen collection or slide preparation, resulting in loss of cellular detail which may mimic malignant cells and can cause difficulties in diagnosis. This table shows how crushed cell can be mistaken for small cell carcinoma. In crushed artifact, nuclei are irregular, elongated, or flattened with smudged chromatin and poor nuclear detail. In contrast, small cell carcinoma shows round to oval nuclei, a high NC ratio, and finely granular, evenly distributed chromatin. The cytoplasm in crushed cells is frequently lost or stretched, whereas in small cell carcinoma it is scanty. For cell arrangement, with crushed cell appearing randomly streaked or clump compared to single cell or loose cluster in small cell carcinoma. How crush artifact occur? In well-preserved samples, distinguishing normal cells from small cell carcinoma is relatively easy. However, in poor preparation, forceful aspiration or rough slide spreading can physically damage cell, causing them to mimic the nuclear feature of SLC. This image illustrates extreme crush artifact. Excessive pressure during handling can elongate nuclei, cause chromatin leakage, flatten cytoplasm, and distort cell cluster, making interpretation difficult. Another important pitfall is inadvertent aspiration. This occurs when the sampling needle accidentally acquires cell from adjacent organs instead of the lung lesion, commonly during FNE. Due to the close proximity of the liver to the right lower lobe of the lung, the needle may pass through the diaphragm and sample liver tissue. This is a diagnostic pitfall because normal hepatocyte can be mistaken for lung malignancy, such as adenocarcinoma. Hepatocytes often appear in cohesive cluster with abundant granular cytoplasm and prominent nucleoli, which may mimic malignant cells. Next, technical fixation, air drying artifact. Proper fixation is essential in cytology. If a slide intended for alcohol fixation is air dried before being placed in alcohol, air drying artifact may occur. This includes cellular swelling, loss of nuclear detail, and artificial hyperchromasia, which may lead to serious diagnostic error. The false diagnosis pitfall, mimicking adenocarcinoma. Slow drying can exaggerate the appearance of reactive cells such as type 2 pneumocyte or bronchial cells. These cells may appear enlarged with dark, smudged nuclei and be mistaken for pulmonary adenocarcinoma. This highlights how technical artifact can lead to false positive diagnosis if not carefully recognized.
Last but not least, let's dive into the final discussion of our topics, which is the advanced tools and the general rules of lung cytopathology. The biggest hurdle is often the metastasis challenge. Why is it so hard to tell if a tumor started in the lung or spread there? First, we have face missing history. Clinical history may not be available or may be overlooked by clinicians. If we misdiagnose a primary lung cancer as metastatic disease or vice versa, the patient may receive entirely the wrong treatment protocol. Second, we have radiology issues. Typically, primary lung cancer appears as a single lump, while metastasis shows up as multiple. But some lung cancer, like bronchioloalveolar carcinoma, can present with multiple nodules, while a single solitary metastasis can easily mimic a primary tumor. Then, the last one is lung cancer mimics. If the cell presents as large cluster of loosely cohesive to discohesive cells, has uniform elongated and hyperchromatic nuclei oriented in the picket fence array and presence of dirty necrosis background, it is most likely a metastatic colorectal cancer. If the cell shows characteristic of low NC ratio, round nuclei, fine chromatin and variable nucleoli, forming multivacuolated cytoplasm that resembling pneumocytes and histiocytes, but with no carbon pigments, it is most likely a metastatic renal cell carcinoma. This is where ancillary testing becomes vital.
specifically immunohistochemistry or IHC. IHC is a type of immunostaining that involves using antibodies and special markers to label parts of a tissue sample. If the antibody recognizes the antigen, it will bind to it and the tissue sample will stain a certain color when viewed beneath the microscope. This test can subclassify non-small cell lung carcinoma into adenocarcinoma or squamous cell carcinoma, especially in poorly differentiated tumor where the cell shape doesn't give us enough clues. As you can see in the image, the cancer slides show a distinct brown positive stain compared to the normal tissue. Beyond just identifying the type of cancer, we now look at the genetics. Once doctors confirm it is primary lung cancer, specifically adenocarcinoma, then they use EGFR testing to determine which drug to use as treatment. EGFR is a protein found on the surface of cells that receives signal to tell the cell when to grow and repair itself. In non-small cell lung carcinoma, the EGFR gene is mutated, constantly telling cells to divide, resulting in uncontrolled tumor growth. Specific drugs called tyrosine kinase inhibitor are used, where it will bind to the EGFR to block growth signal so the cell stops dividing and the tumor begins to die. To wrap things up, we must remember two golden rules. First, pathologists should never diagnose malignancy based on cytomorphology alone without checking the patient's clinical history to ensure differences between primary lung cancers and metastasis. Familiarity is also our best defense. Knowing the mimics and the common pitfalls is the only way to avoid misdiagnosis. That's all from us. Thank you for listening.